In the last topic, we saw that expanding public insurance programs like Medicaid comes with a real cost to taxpayers in terms of increased utilization and the need for taxpayer dollars to finance that use. What benefits does that increased cost generate for beneficiaries or enrollees in the program? How much financial protection does it provide? How much does health change? Now I'm going to present some evidence on what we see when we expand Medicaid. There are many studies that evaluate the multifaceted effects of expanding public insurance. One that I worked on with colleagues here in the Health Policy and Management Department at the School of Public Health examined the mortality among populations who were covered by Medicaid in states that chose to expand, compared with the mortality in similar populations in states that chose not to expand. So this kind of study is called a difference in difference estimate. We looked at trends in a state that didn't expand before the expansion period and trends in a state that did expand. And then we saw how those trends changed when the state that chose to expand changed its program. That break in trend relative to a control state tells us the potential effects of the Medicaid program. In that study, we saw that in the states that opted to expand to low-income adults, a similar population to the ACA, there was a substantial lessening of mortality in the population relative to the control states. There was about a 6% relative decline in mortality rates for that population, and that decline in mortality showed up in the subpopulations or the groups of the populations that we would have expected to be most affected by the Medicaid program. We saw parallel increases in access to care and improvements in self-reported health. So this evidence is strongly suggestive that people who are newly eligible for Medicaid have improved health outcomes, and in particular mortality, which is obviously a very important health outcome. There are challenges to studies with this kind of design, though. One might be concerned that states that expand Medicaid are doing so for a reason that goes along with other public policies. Researchers, like me and my colleagues, do our best to take that into account. You can never be 100% sure that you have, which is why it's important to have evidence from multiple sources before gauging the effect of a program that has huge public policy import. So the second set of evidence that I'd like to present for you comes from the Oregon health insurance experiment, where, as we've discussed, Oregon expanded insurance based on a lottery. They had 90,000 people on a list, 10,000 people were newly insured. We compare the outcomes of people who were drawn in the lottery to those who were not drawn in the lottery. And we wanted to gauge not only the costs in terms of increased healthcare use, but the benefits in terms of improved health outcomes and financial security. So the first outcome that I'll talk about is financial strain. In Oregon, we saw a substantial reduction in all sorts of measures of financial strain when people gained access to Medicaid. We looked at credit reports and we found that people were 25% less likely to have a bill sent to collection because they hadn't paid it. Now, this is a very important outcome for individuals. When you have a bill sent to collection or another black mark on your credit report, that adversely affects your chances of being able to get a loan, but it also may have wider ranging consequences. Potential employers may check your credit report. Even landlords who are renting rather than selling may check your credit report to see if you're going to be a good tenant. So this has serious financial consequences and life consequences for people who get those bills sent to collection. It also has important implications for the providers who gave that care. When a bill is sent to collection, that doesn't mean that the provider gets paid. Fewer than 2% of the bills that are sent to collection are ever collected upon. So this is a sign of providers delivering care that was not paid for by the patients who got it. So having that reduction is really important for the system as well as the patients. We saw improvements in other measures of financial strain. Having catastrophic out-of-pocket medical expenses or medical costs that are more than 30% of your income virtually disappeared when people got access to Medicaid. We also saw a big drop in the likelihood of having to borrow money to pay other bills or not being able to pay your other bills among the population that got Medicaid relative to the control group. So this bespeaks a much more financially secure and stable situation for patients who were newly insured. And remember, that's one of the primary goals of insurance, is to improve financial well-being. We saw that in spades in Oregon. The real punchline that people care about when thinking about expanding insurance, though, may not be those financial effects, although I think they're really important, but is probably the health consequences of gaining access to care through insurance. And we looked at a range of outcomes for people in Oregon. We started with self-reported health. We asked people about how their health fared, and people reported that their health was much better. They were much more likely to say their health was good, very good, or excellent relative to fair or poor. They're much less likely to report health decline in the last 6 months. They reported they were much less likely to suffer from depression. They had fewer days missed from their usual activities because of adverse health. So all of these speak to an improved sense of health and well-being. But we also want to measure these things directly. And we went to people's homes or had them come to our clinics and did some direct measurements of their health. This is important not only because those measures are important to the individuals and to policymakers, but also because it's very hard for people to accurately tell you about their health. For example, suppose you want to know the effect of insurance on blood pressure and you ask people, do you have high blood pressure? Someone who hasn't been to the doctor is less likely to know about underlying hypertension. So if you ask people whether they have high blood pressure, you may get the perverse result that the people with the most access to healthcare are the most likely to be able to report that they have high blood pressure. And that doesn't mean that the healthcare is causing the high blood pressure. It just means it's increasing their awareness of an underlying health risk. So for that and many other reasons, we thought it was very important to measure people's health directly. We assessed depression using a clinical screener. We got blood samples to measure cholesterol, diabetic blood sugar control. We measured blood pressure and obesity. And the results paint a nuanced picture of the effects of the program. There was a dramatic improvement in depression. Rates of depression in the population covered by Medicaid dropped by 30%, which is a substantial reduction, and depression and mental health poses a serious health burden for this population. So that's an important change. We did not, however, observe measurable improvements in blood pressure, cholesterol, or diabetic blood sugar control. And this was surprising to people who thought that insurance was likely to have an effect on managing these chronic conditions, and raised a lot of questions about why we weren't seeing such an improvement. There are a couple of reasons that our effects might or might not be representative of the effects of expanding insurance more broadly. I mentioned before that we only looked at the first 2 years after insurance coverage, so people wonder, might the effects differ in the longer run? Certainly they might, but the conditions we looked at, such as high blood pressure and high cholesterol, have medications available that, if taken as directed by the clinical literature, have the potential to improve those outcomes within 6 months rather than the 2 years that we looked at. So perhaps effects at 3 years might not be so much better than effects at 2 years. We also looked at a pretty large sample size, about 13,000 people. Maybe the sample size isn't big enough. The confidence intervals that our study generated included both moderate improvements in those conditions and moderate declines in those conditions. You might think that with a bigger sample we might be able to detect a smaller effect, and that's certainly true. That said, we worked hard to look at different subsets of the population that would be most likely to see improvements, such as those who'd been diagnosed with high cholesterol or high blood pressure before, or the older subset of the population, and in none of those cases did we see improvements in those conditions. We did see an increase in diagnosis of and medication for diabetes, and that population was smaller, so it's possible that there are more substantial improvements in blood sugar levels for that population. But I think this offers some cautions in the hopes that expanding Medicaid to a low-income adult population will improve the outcomes of chronic conditions and improve disease management substantially within the first 2 years. This is an opportunity to introduce some additional cautions in interpreting these results, however. Every state's Medicaid program is different. The program we looked at in Oregon was a fairly typical Medicaid program covering inpatient, outpatient, and prescription drugs with no co-payments for patients. It paid providers similarly to what other state programs pay providers. In the period since then, Oregon has amended its Medicaid program to move towards coordinated care organizations. Other states have different kinds of Medicaid programs, so our study can't tell you the effect of a different Medicaid program on the health outcomes of a covered population, and it's important to take that into account when thinking about what states are going to choose to do with their Medicaid programs in the coming years.